Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesiologist and a critical care physician at Hopkins. I'm an active member of Pikesville Volunteer Fire Company. I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of the medical director's office, the EMS office, Chief Nats, EMS Training Academy staff, and Captain Lenny Stewart, thank you. Thank you for what you guys do every day to help our community. And thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, who is also a volunteer at Pikesville, who is helping us with our Zoom platform. Ashley, towards the end of the training, we'll be putting a link in the chat. If you want your MIM CEUs, click that link. We'll be sending it out a couple of times at the end. Fill out some information and get your MIM CEUs. If you have any questions about your MIM CEUs, have any trouble signing in, or have questions about past participation, please hang out with us afterwards, and we'd be happy to answer your questions. Also, a big shout out tonight to Terry Sapp. Terry works for Baltimore County, and he also is a volunteer at Pikesville. Terry is the one who brought us tonight, our speaker, to us tonight. So with that, we are super excited to have with us Sara Riker. Sara spent 20 years in the field of child welfare. She is now in private practice, specializing in trauma and PTSD for first responders and trauma survivors of all ages. She was also a foster parent of a teen boy who has since aged out of the system. And what she failed to mention is that she has multiple bulldog puppies and also a husky. Sara, thank you so much for being with us tonight. We super appreciate you.
Well, I'm really excited to be here. So thank you very much for this opportunity. I really love sharing information with the community about trauma. And I also love even more providing first responders, EMS, fire, police, social workers, anybody who has survived traumatic experiences. It is my biggest passion to help people heal. And so what I want to do today is
Sara, I messed up and I put you on mute. I'm so sorry. Thank you so much. So sorry.
Do I start over?
No, you're great.
Okay.
Just the last second.
Okay, no problem. You can put me on mute anytime.
No, God, no.
So I'm here this evening to bring information to you guys, and also to really talk about kind of breaking some cultural barriers that are associated with first responders, who might be kind of struggling, especially some people who are, a little newer to the field, who are being exposed to really difficult things every day. You guys have really difficult schedules that are not conducive to self-care or sleep or eating well. And so what we're going to do is just really talk about the impact that this work has on you and your brain and your body. And we're also going to talk about the impact of trauma on the community at large. So most of the time when you guys are responding to, your emergencies, you are probably meeting people in the community on one of the worst days of their lives. And so what I want to help you do is have a little bit more understanding maybe of what some people are going through and what you could also be going through, because I want to help you guys with information. Information is power. And I want to help you also know that it is okay to ask for help. So I hope for a robust conversation. I hope that I get lots of interruptions so that you don't have to hear me yammer on and on and on, because I can talk forever about this subject. So here we go. We are going to talk about breaking barriers. We're going to talk about addressing the stigma of trauma, understanding trauma on a very rudimentary level, understanding, what PTSD can look like, what other acute stress disorders can look like, how it impacts the body and the brain, and what we can do to start to access some healing. So there's a really good informational book called The Body Keeps the Score by Bessel van der Kolk. And he is a really robust researcher. And he put together this book because he has spent a lot of time providing therapy to trauma survivors. And the book, so a lot of this information is derived from the book and from some of his trainings. And so we're going to talk about psychoeducation. We're going to talk about how the brain and body works together when we are under stress and duress. We are going to talk about some basic grounding techniques to help calm your nervous system when you are under stress on scene, or when you're trying to help somebody calm down. And then in the end, we're going to talk about how all of this affects us, what we need to look for, and the types of treatment that we can access that could really help provide some relief and symptomatic relief. So I just want to talk about the brain for a second. The brain is the organ that makes our muscles move. It is what makes our whole internal infrastructure work and operate. So the brain is all about taking care of our body. And taking care of our body requires movement. And so trauma is just about the body experiencing something and it becomes immobilized. When the body starts to feel helpless, the body then numbs out, and the body has difficulty fully engaging in the present when it is under significant stress and duress. And it makes it really hard to feel alive, to feel present. And it makes it really hard not just to be present with yourself, but it also makes it really difficult to be present with others around you. So what happens is that when we experience trauma, if we experience a car accident, a difficult, really jarring scene that you guys show up on, somebody yelling and screaming, an aggressive patient, or any other types of trauma that are out there, medical trauma, surgeries, the list goes on and on and on. When we experience this trauma, our brain and our body, they work together symbiotically to instinctually protect you. So what happens is that the body responds, our internal system responds faster than our logical thinking brain. And these are our instincts. So I just want you to think for a moment about driving a car. You're driving and all of a sudden a rock is flung toward your windshield and you flinch. Your eyes blink, you flinch, you clench your fists, you clench the steering wheel, your muscles tense, you gasp for breath, and you might even kind of like jolt the steering wheel out of the way. Even though logically we know that there's a windshield that protects us, our instincts override that logical thinking. Our heart starts to pound. It pumps blood to our extremities, getting us ready for the biggest fight or flight of our lives. So this is what we call the limbic loop. So our instinctual brain responds faster than logical thinking when we are faced with stress, duress, trauma, or anything that is going to overpower us physically and emotionally. So what happens is that our logical brain goes offline. The blood actually flows away from our logical brain and it goes to our survival brain. It goes where it's needed, just like a cut, just like if we cut ourselves or injure ourselves or break a bone, you know how the blood just kind of rushes to where it's needed. The same thing happens in our brain. And so our survival brain gets kind of inundated and it kicks on really, really fast. And then it quickly communicates with our endocrine system. And all of a sudden, we are flooded with adrenaline and cortisol and dopamine and norepinephrine. And all of this happens in a split second, faster than logical thinking. So if you can imagine how fast our instincts are, that puts our body in a state that does nothing but protect us by making us go as numb as possible. That's our instinctual trauma response. It is instinct. We cannot snap our fingers. We cannot ask for a shot of adrenaline, although that would be kind of fun. We cannot ask to raise our heart rate. We cannot ask to dilate our pupils, to scan the area. We can't consciously make these decisions. This is all built into our survival brain, into our instincts. Next. Why isn't this going next? Oh, here we go. Okay. So, I am a social worker. I'm a licensed clinical social worker. I'm not a doctor, but we do have some doctors in the room. So feel free to jump in anytime. But I just kind of want to give, a very, very basic view of the brain. So the brain is in two hemispheres, the left and the right. We hear all the time about left brain people who tend to be logical, analytical, factual, and mathematical. And we talk about right brain people who are creative and passionate and intuitive and empathetic and imaginative. And then there's a little piece called the corpus callosum that develops at around the age of 3, which we refer to kind of as a communication highway between both parts of the brain. And the corpus callosum is really critical when it comes to helping the brain process trauma. So when we talk about a traumatized brain versus a healthy brain, we are really talking about how the brain is impacted by stress. So if you go through life and you have a really, lovely, grounded life with very little trauma, then you can achieve some balance, and your learning brain can stay intentionally active. And the learning brain is our voluntary brain. It is responsible for our conscious thinking. It is responsible for our intellectual ability. It is responsible for decision making, for walking and talking and exercising and running and language. And it's also responsible for perception and for taking perspective. Our learning brain helps us understand the gray involved in life, nuances, body language, tone. It helps us process all of these things really in a voluntary way. It understands ambiguity and it can see the bigger picture. And our learning brain helps us regulate our emotions because of all of these functions. So it helps us stay calm and peaceful. It helps us be curious and playful. Our survival brain in the back has one responsibility, and that is to keep us safe. It is hyper-focused on threats. It often thinks in black and white terms. It is what feels like panic in our body. It can be obsessive in nature. It is afraid of things. It wants to get things over with. It doesn't like making mistakes. It can be filled with self-doubt, misperceptions of the world. But all it's really trying to do is just save your life. It communicates with the endocrine system, and it does it faster than our learning brain. And I'm going to say that over and over and over again, because I really think it's important for us to really realize what is happening in our body when we are stressed. So what the survival brain does is it senses danger and it prepares our body for pain. So we all go through this really rudimentary response system when we are under stress and duress. we go through a series of really basic responses that is nothing but our instinct. And this is what an ITR therapist, an instinctual trauma response therapist, calls the ITR. So if you think about a really stressful event and you slow the reel down and you observe yourself going through this, then you will see that you react and respond much like any living thing. So when we get scared, we have a startle response and we gasp. Our muscles tense, our heart and our stomach drops, our pupils dilate so that we can scan the area. And then instinctually, we go right into fight or flight mode. This is our instinct. Our instinct is to either fight or flight for our lives. So we get an adrenaline rush, our heart pounds harder and faster, our breathing becomes shallow and quick, trying to get more oxygen to our lungs, trying to bulk up our muscles so that we can fight or flight ourselves and save ourselves from whatever is happening. So if you can imagine, you're running a marathon and you can see the end. You can see the end coming and you are ready to collapse. And you cross over the line and all you want to do is flop down. But a bear comes out of nowhere and starts chasing you down. Oh, and I forget to mention that you're also barefoot and running on nails. So when that bear comes out of nowhere after you have just run a marathon, your body will keep you safe and it will give you what it needs to help you survive. I think it's fascinating. I think that our bodies and our brain is really incredibly amazing when it comes to survival. But sometimes when we experience these things, we are overpowered by whatever it is that's chasing us. And so we freeze. It's instinct. When we freeze, our cortex, our thinking, logical brain goes offline. Our body is naturally, instinctively flooded with endorphins. It is flooded with adrenaline and cortisol and norepinephrine and dopamine and probably 14 other chemicals to make us go as numb as possible. And so what happens is that our brain gets overwhelmed with all of this. And after we freeze, we kind of go into an altered state of consciousness where we feel like we're totally disconnected from our head, from our body. And we're in this altered state of consciousness, like a daydream. It's almost like after, during a really stressful event, we can't quite ground ourselves. We can't quite grasp reality. Time is totally warped. And you will see and hear this as people are talking about their traumatic experiences. They will talk about these stages. And so after somebody experiences that altered state of consciousness, some of that starts to clear, but we go into another state, and it's called automatic obedience. Other people call it fawning. And it's essentially when we become responsive to orders. So we've just been through something really terrible. We feel a little bit out of sorts. We can't quite ground ourselves. Our cortex is still offline. We can't access problem solving or language, but we can listen to directives. So if you guys show up on scene and let's say you show up to a car accident and somebody is just kind of dazed and confused. And you say, come over here. Why don't you just sit down with me so I can check your vitals? And they just like in waxing and waning movements, they follow your directive. Well, they are actually in an instinctual trauma response mode called automatic obedience. It is survival. The last stage that we all go through is something called self-repair. This is different than self-care. So self-repair is when our cortex comes back online, our body pain returns, and we take that big breath, like, phew, that is over. Whatever that was that we just went through, it is over. And now my body has to repair. My body has just been through something, or emotionally, we feel like we've just been through the ringer. And a lot of us need to repair in many different ways. So a lot of us have to sleep. A lot of us reach for something comforting or self-soothing. Food. Some of us reach for alcohol. Others reach for drugs. Others, really start to try to repair in really maladaptive ways in an attempt to self-soothe. So we're going to talk about this, especially as first responders, in a little bit. So we have to pay attention to how we repair, and we're going to train ourselves to start to engage in really healthy habits, to start to repair after really difficult and traumatic events, instead of turning to those really harmful things that tend to sometimes go along with first responder culture. And it's just going to be really critical, like in your journey through the rest of your life, that we really try to pay attention to our body, what we put in it, how much rest we get, and really decreasing our stress intentionally as much as possible. So here's just a little bit more information. So trauma is not stored in memory the way typical events get stored. Trauma is often stored as emotional memory, or what is also considered implicit memory. So it is stored in the body. It is not stored in language, and it is not stored in photos, like a photographic memory. Instead, trauma is stored in bits and pieces, in sharp, jagged fragments, and there's no timestamp on trauma memory. Brain scan research shows that traumatic memories are encoded primarily as bodily and emotional feelings without words and pictures. So if you think about a memory, if you think about the last great barbecue you went to, or the last great party you went to, you can pull up that imagery, you can describe certain things, and you can tell a narrative that has the beginning, a middle, and an end succinctly, and you can put the memory away. Traumatic memory is different. It is not stored in sequential order. It is not stored in any specific way, and it still feels very alive today in our body. And so we have to learn how to train the brain to look at our traumatic memories very differently. These implicit memories do not carry with them an internal sensation that something is being recalled. Instead, our body acts out what it's feeling. And this is going to be important for later. So what happens is that our emotional memory converts the past and it turns it into an expectation of the future. So if you think about some things that we have survived in our past, a lot of times that gets encoded in this body sensation that history is going to repeat itself. And sometimes the worst experiences in our lives continue to persist today, and it feels as real today as it did back then. And this is a part of a diagnosis for post-traumatic stress disorder, or complex post-traumatic stress disorder, or acute stress disorder. When the body is reliving something, it is that sensation. And that is why PTSD is alive and real, because it lives in our body and it plays out. So if you think about yourselves or a client, something that stands out, and if you think about maybe you or somebody else, has overreacted to something that seems really small and insignificant, like the dishes. Or you see somebody making a mountain out of a molehill. Or if you see a patient really on scene who seems to be totally acting inappropriately to what is actually happening, then more than likely, what you are seeing either in yourself or in somebody else is implicit memory playing out. So I just want you to think about that for a second. I really just want you to think about times, even in your own lives, where you may have just totally overreacted to something insignificant. And then I want you to think about maybe that was related to a past traumatic experience that you had, and your body is playing out the parallel life right now. So when that happens, this is what we consider to be a trigger, an emotional trigger to something. Again, the human body and our brain is built to work together to be as self-protective as possible. But sometimes it automatically reacts to any cue indicating the possibility of perception and danger, either physical or emotional. And when we experience trauma over and over and over again, then our brain gets conditioned to a pattern, and it can recognize that pattern from a mile away, and it can see it, it can anticipate it, and if you are going to brace yourself for the worst case scenario, this is a trigger. And remember earlier on that our perception changes. So sometimes we don't see the bigger picture, or we can't calm our nervous system down fast enough to be able to see the bigger picture. And so when you are triggered, or when you are working with a patient that is triggered, just know that whatever they are experiencing is probably a perception of danger. And when we get triggered, sometimes we experience overwhelming feelings, sensations, and impulses that convey, I'm in danger. So I want you to think about your own things that may set you off a little bit. I know for me, when somebody lies to me, it is a huge trigger, and I can tell you why. I was raised by a liar. And I remember the first time my foster son lied to me, and in my mind, I wanted to lose it. My whole body was shaking. I couldn't figure out what was happening. And until I really slowed down and figured out that I was really triggered by my foster son lying. And so I had to really kind of work through that. And I have probably a million examples, but I think that that's just, it can be a really common example that people can relate to. Maybe your spouse gets triggered because you put the dishes in the dishwasher wrong, or you didn't do the laundry the right way. And maybe your spouse or your partner kind of loses it over something like that. More than likely, it had nothing to do with the dishes or the laundry. More than likely, it had to do with them not feeling heard, seen, or feeling valued or validated in that moment. And their whole body was reacting and responding to this thing that reminded them perhaps of a time that they were just deeply wounded. So these are triggers, and these are things that I want you guys to think about. Over time, the brain gets conditioned to respond to danger signal. And this is interesting. So our body remembers sensations, senses, smell, sight, touch, and our olfactory system, our nose, our scent system is one of the strongest memory systems there is, and it is one of the fastest triggers there is. So if you catch a whiff of, I don't know, Old Spice, and it reminds you of, of your grandfather, and you can get, this immediate sensation either of whatever your grandfather reminded you of. So your body is actually responding to that memory before logical thinking. Our body also holds on to anniversaries and memory dates around seasons and months of the year. And so when I worked in child welfare for a really long time, and I primarily worked with substance using parents, and my parents would typically do really well. They would get clean, they would get on treatment, they would do whatever they needed to do, and then they would relapse. And we started noticing patterns around people's relapse. And those patterns tended to fall on the anniversary date of something really traumatic, an anniversary date of a grief or loss or something big. And so when we started noticing these patterns, our clients didn't notice these patterns until we helped them point it out. So then we could treatment plan around like really difficult anniversary dates. And I just always thought that was really interesting that our body remembers dates before we can logically put things together. So it's just another fascinating way of how our whole internal mechanism just kind of works together. And so a lot of times when we're triggered, it sends us right into that whole limbic loop of startle, fight, flight, and freeze.
So there is a comment grounding the concepts of PTSD, trauma, fear, and fright in medicine, science, and the biochemistry of the brain and body helped me to see the issues as a whole spectrum of problems where the psychological and mental health components are just a portion of a multi-system experience.
That's right.
That's really good. And somebody else actually pointed out that the book that you recommended is available as an audiobook at the library.
Yeah, thank you, Ashley. Yeah, and I'm going to get into that whole system because there's a whole system approach to healing as well. And so thank you for really pointing that out because it is so deeply integrated into our mental health, our physical health, all of it is impacted. So here are some common, traumatic triggers. It's not limited, but with the population that we tend to serve and with ourselves, we have these really common trigger points. And sometimes it is a perception of abandonment. Triggers can be caused by a flashback of a really difficult incident or a feeling. Sometimes being the center of attention or having the perception of being the center of attention can really make somebody get flushed and hot, and they start to have this like body reaction, this really visceral reaction. I don't know anybody who does this. That's a joke. But some people get really triggered by criticism and feedback. And I say it's a joke because I'm one of those. So that, if you get criticism or feedback, even if it's constructive, it kind of deeply resonates in that guttural punch sometimes. And you just immediately think, I'm not good enough, or I'm a failure, right? So that limbic survival part of the brain goes right into kind of all or nothing thinking and catastrophic thinking, and I'm just a failure and I'm not good enough. And then we're kind of swimming in all of these really hard negative thought patterns. Sometimes some people being told no is a trigger. My foster son was completely triggered by the word no. And I described it as he just would go sideways. I've never seen anything like it. And our whole household would be turned upside down for days if I had to tell him no, if I had to set limits and boundaries. It was really hard to work through sometimes. Being ignored. Sometimes eye contact can be very triggering to some people. Loud noises. You see people that have a really strong startle reflex. Sometimes getting a whiff of a scent. Sometimes feeling emotions or feeling vulnerable can be very triggering to some people because they have worked their whole lives to not be vulnerable. Sometimes nighttime or darkness can be very triggering. Intimacy can be. The idea of commitment, confrontation. Sometimes, especially with patients, they can just be triggered by your gender. And that can be really hard for us, especially in the helping profession. When we show up, we just want to help. We just want to treat people. And they can be very triggered sometimes by just our gender. And authority figures can be very triggering for some people. And sometimes we are considered authority figures. So just keep some of this in mind. So here's the thing. Trauma usually manifests itself in the context of relationships. So it shows itself when we are typically in a relationship of some sort. So our trauma comes to the surface when we are in intimate relationships, parent-child relationships, in our friendships, and in work relationships. So here's an example. Here's an example of abandonment. So if somebody was abandoned by a parent at a very young age, that abandonment gets encoded in that person's body. The body records the memory. And the person may not be aware of this. So as that person grows up and becomes and engages in a committed relationship and a partnership, and let's say an argument ensues, and the abandoned person and the partner are arguing. The partner says, I need to walk away. I need to walk away and take a break. I will come back, but right now I just need some space. The abandoned person, all of a sudden, is completely triggered, having a full body visceral takeover, and interprets this information as abandonment. And they do what? What do you think they do? They can, yeah, Sean, go ahead.
Yeah, no, I think people will respond in the chat if that's a question.
Oh, yeah, it's a question or rhetorical, whatever. If anybody wants to respond. Or not, which is totally fine. So a lot of times, that whole body takeover, that abandoned person is gonna not let their partner leave the room, or they're not gonna let them, take that space, or they're gonna beg and plead for their partner to stay, or they're gonna physically block their partner from leaving, right? So they're having this whole visceral body takeover, and they are really acting outside of maybe the context of what's happening in the here and now. So this is how it plays out. That abandonment as a young child ingrained itself deeply into this person's, deeply imprinted into this person's experience and psyche and body. And now there's a perception of abandonment happening in the here and now. So the person is having a full body takeover. That's how trauma can manifest itself in relationships. And things escalate. So this is what leads to domestic violence or interpersonal violence. It's what can lead to physical abuse and neglect, and a whole host of things can happen when somebody has that kind of visceral takeover. And you could be responding to somebody who is still in that instinctual trauma response mode. So what happens is that, you know, there's like 3 tiers, and somebody brought this up. There's a lot more than 3 tiers, but essentially what happens is that we have this biological response, we have this biochemical response, we have the surge of adrenaline, norepinephrine, dopamine, cortisol, and all of it, which leads to a behavioral response of fight or flight, which leads to an emotional or psychological response, that psychological wound that gets us into that all or nothing thinking, that gets us into, you know, that really harsh inner negative thinking, you know, that negative self-talk that we tend to kind of fall into over time. And here's the thing, this biological response, this whole body biological takeover, now we're swimming in all of these endorphins. It takes like approximately 30 minutes to an hour for our body to start to get back to homeostasis. And all of that has to go somewhere. So either we cry or yell. So we're like emanating some of this. We're trying to like purge it out of our system. Some of us have, you know, irritable bowel syndrome. Some of us cry. They find cortisol in tears. So that means that, you know, tears is a biological need to cleanse our body, to cleanse the system. Some people under stress and duress, they throw up. So there's a lot of things that the body actually has to do to regulate itself to get back into homeostasis. So the more we know, the more we can do. And the antidote to this really intense experience in our body is to be aware and to be mindful that there are some things that we can do. So when you arrive on scene, if somebody is totally in a heightened state, we want to decrease the stimulation around them. We want to slow our speech, lower our voice. We want to regulate our own breathing, and we want to help them to breathe. We want to change positions, maybe help them stand up, maybe help them walk or change seats. And we want to learn some grounding techniques that we can use either with ourselves or with, you know, our patients. So, you know, there's a very common grounding technique, the 5-4-3-2-1 method. If anybody wants to take a stab at that. I'm not really sure if anybody wants to jump in.
What's 5-4-3-2-1? How does that work?
So if you're with a client who's just kind of in a heightened state, you can tell them, like, let's do some grounding. Tell me 5 things that you can see. Tell me 4 things that you can, it's kind of igniting all of our senses. So it's 5 things you can see, 4 things that you can hear, 3 things that you can smell, 2 things that you can touch, and 1 thing that you can taste. So you're bringing people back into their body. It's just a technique. We can also do diaphragmatic breathing. So really just helping people draw attention to their breath, to their body, helping them slow their breathing down, really trying to calm that sympathetic nervous response system that's happening. But you really want to stay calm yourself. You really want to, you know, engage with people, you know, with some distance, just with a calm, open demeanor, with confidence, no sudden movements, and just maybe help somebody acknowledge, like, wow, today's a really bad day. You must be incredibly overwhelmed. And that's, people just want some acknowledgement. So that can just really help people calm down. I think there's somebody in the chat that just, yep, so I'll get there in a second. Thanks for asking, Jenny. She asked, do you use eye movement desensitization and reprocessing therapy, which is EMDR, in your practice? So I'll get there. Do you mind if I just like hold off on that? because I'll get there in a second. My computer is not responding well. Come on.
Mm,
I want to go to the next page. Okay.
You got it. Good job.
Thanks. I don't know what I'm doing. So
Getting
here's the
great
thing. Over time, exposure to trauma, complex trauma, it really does change the brain. And our brain loves patterns, so it adapts and it kind of gets conditioned to certain things. And we adapt really quickly to really difficult things. It's a part of our built-in survival mechanism, but it can be really hard on us. So remember, that the front of the brain is devoted to problem solving and really voluntary things, social interactions. It helps us communicate, interact, self-regulate, and problem solve. And the back in the brain is concerned about our survival. So it makes sure that we eat, that we breathe, that we sleep. It regulates our blood pressure. It helps us, survive under stress and duress. But over time, our brain changes. Over time, traumatized people start to experience disturbances in their eating, in their sleeping pattern, in their perceptions of the world, and in their own self-talk. People start to really feel out of tune and out of sync. And that's where, therapy could be really useful before we get to this place. But usually people don't start to access therapy until they get to this place where they just feel like, I don't feel like myself. I'm totally acting out of line with, within myself. I used to be able to handle stress. Now I can't, so we'll talk about all that in a second. But I really just want you to understand that, our brain is complex. We are complex. And, and there's just really specific parts of our brain that help us in traumatic situations, that help us survive, that help us also process trauma, but that also get impacted by trauma. So we have the brainstem. Most of the information we receive in the world hits our brainstem, shoots up. The thalamus kind of distributes the information to the parts of the brain that need it. And then we have this part of our brain called the amygdala, and the amygdala is our smoke detector. So the amygdala responds to stimulus faster than most other parts of the brain. And the amygdala is what kind of sets us in motion into fight or flight. It's also responsible for our immediate pleasure center. So this is where that satiety comes into play. This is where maladaptive behavior patterns start to really take shape. So basically sex, drugs, and rock and roll, the amygdala loves. And it also is very, very reactive to danger. The hippocampus is responsible for a lot of things. It's responsible for memory and learning. And it's responsible, it's also our air conditioner. So it helps regulate our cortisol. The problem is when the hippocampus is under severe stress and duress, it gets overwhelmed with cortisol, and that's like the camera lens of our memory system. And so when the hippocampus is clear, it takes a panoramic view of events and it stores it in long-term memory. But when it gets overwhelmed by stress and cortisol, the camera lens goes blurry. And this is why trauma gets stored very differently in those bits and pieces and fragments. And over time, under a lot of stress, the hippocampus actually starts to atrophy, but it can rebound with a lot of self-repair and a lot of self-care. The insula is also a part of the brain that's responsible for emotional regulation. It's a really hard part of the brain to heal, but There are studies that show that grounding, meditation, showing up to therapy, and really just doing a lot of deep breathing and practicing gratitude helps the insula repair. And then we have our cortex and lots of parts to the cortex, which is responsible for that logical thinking part. So, what the cortex does is it needs to start to recognize that the instinctual brain takes over and that we go through all of this stuff and it's with intention and purpose. And so we want to help strengthen the communication between the cortex and the limbic part of the brain, which gets us into therapy after I talk about this slide. Sorry. And so again, this is just a reiteration that when you come across somebody, or if you feel like you are impacted by trauma, or you're meeting with a patient who is impacted by trauma, that they can really present as dissociated, or they present as totally uncomfortable in their own skin. They don't feel calm or open to the world. And they're responding more to an internal stimulus that seems to be interfering with their sensations, that doesn't help them calm down. So if you ever meet with a patient who is having a really hard time paying attention to you, who asks you to repeat the question because they couldn't quite register or process what you're saying, then you just need to kind of slow it down and break up your questions, one question at a time, and just understand that they are in a trauma state. Okay. So traumatized people don't ever feel well in their bodies. There was a whole study done. There's a TED Talk on the ACEs study. It was a study done by a pediatrician who worked in a clinic in San Diego. And she studied the adverse childhood effects of on the body. So she followed people that came from really stressed environments. And she realized that as they grew up, they had a shorter lifespan, they had more chronic disease, comorbid diagnoses, higher blood pressure, higher diabetes, higher substance use disorder. And so she really just started to recognize how impactful stress and trauma can be on our lifespan. So if you're ever interested, it's a really interesting TED Talk that can talk about how adverse childhood experiences impact you. She has a questionnaire, it's 10 questions. And, it's really broad. They're really broad questions, but it kind of gets to the heart of growing up in really stressed environments and paying attention to how we take care of ourselves. So overall, our brain is responsible for a lot of things. It is responsible for learning, for perception, attention, and processing. It's responsible for keeping us alive. And over time, stress really impacts this. So people can present with anxiety, depression, ADHD, obsessive compulsive disorder, personality disorders. And really what it is and that trauma causes a disturbance in perception. It causes an internal stimulus disturbance and a disturbance in perception. And so whenever I have somebody come to me and they say, I have depression, I have anxiety, I think I have ADHD, I think I have adult onset ADHD, I really struggle, I think I'm bipolar, I've been told I have borderline personality disorder. When I start to see people presenting with a lot of different differential diagnoses, my first question is always, tell me your story. What have you survived? And then we start to put the pieces together. So trauma can lead to an impairment also in imagination and mental flexibility. So if you ever meet somebody who's really rigid, They're always right. They don't want to hear or see the world. They don't want to, take on anybody else's information or perspectives. Then, they've probably somewhere along the way experienced some trauma that has impacted and disturbed their perception. And it's really hard because it's like a hallmark of being a human. We have the ability to take perception and and perspective changes with information. And with information, we get to strengthen, ourselves as a collective. But sometimes trauma gets in the way of that. And people who experience trauma over and over, they play that same old reel over and over and over again. And so when you access therapy, we try to break that reel. We try to give them a new narrative, help them detach, and then help them settle into their whole mind, their whole body, and really start to embrace healing. So these implicit memories, again, trauma survivors don't have memory, they have symptoms. Some of these symptoms include intrusive thinking, disproportional, responses to stimulus, and trauma survivors tend to carry a lot of fear, anger, shame, and dread. Sometimes they have thoughts that can predict the future. Sometimes they have impulse to run or to hurt their bodies, to drink, to use, to hide, or to avoid going out. Some people experience somatic sensations: spinning, dizziness, pain, heaviness, floating, tingling, unexplained tingling, numbing, noises in the head, loss of hearing or vision. And some people have really yearned for contact, or they experience really painful loneliness. They experience a sense of abandonment. I had a client, she was late. Well, I thought she was late one day. She's never late. And I couldn't find her. And I could hear this really heavy breathing coming from a small room. And I went into that room and she was on the floor. Her forehead was on the floor. She was in the dark and she was breathing really heavy. And she just kept saying, "My nose is tingling and my arms are numb." And she couldn't move. And she was experiencing somatic sensations. And I had to get on the floor with her and help her kind of use these grounding techniques, get her back in her body, helped her stand up, help her kind of shake it off, and really help try to ground her again. But it was a really pronounced somatic sensation that she was having. And this happens kind of to all of us sometimes. So again, with the hippocampus, I love the hippocampus. I probably don't need to review this again, but again, the hippocampus is critical in memory storage. And we help in trauma treatment, we help teach the hippocampus that our traumatic events have a full narrative, that they are over, and it helps pull it out of implicit memory into long-term memory like a faded photograph. So the hippocampus is just a really critical part of the brain and trauma therapy that we engage. All right, so here are some warning signs. As first responders, you guys are under stress all the time, all of the time. As soon as those bells go off, as soon as your lights and sirens go off, your body is reacting to stress. As first responders, you are at higher risk than most professions for trauma, for complex trauma, PTSD, suicidal ideation and attempt, depression, anxiety, and strained relationships. These are warning signs. If you feel like you are experiencing depression, irritability outside of the norm, a decrease in your interest in things that you used to be interested in, if you're engaging in more numbing activities, an increase in alcohol use, if you feel like your concentration is decreased, or you're having a hard time focusing, or those reports are stacking up and you just can't seem to get yourself to them, or if you're experiencing insomnia, if your nervous system is dysregulated, or if you start to feel hopelessness or foreshortened future, if you're internalizing things as shame or self-loathing, or if you're having flashbacks or nightmares, or maybe you're having a heightened sense of hypervigilance, you're just always scanning the crowd, scanning the room, and you can't seem to relax and enjoy being present or in the moment, or you're starting to develop a worldly sense of mistrust, maybe some social anxiety or panic attacks, an increase in chronic pain, weight gain, weight loss, eating disorders, suicidality, self-harm, or addiction. These are warning signs, and I implore you to get help if you need it. I think you should start to get ahead of it personally. And if you're not experiencing really debilitating symptoms, I think it's worth seeking out some kind of trauma therapy, because already what you do alone is enough to cause some stress issues. So our treatment goals are always to learn how to feel well, to feel alive, and to be as present as possible. There's lots of treatment out there to treat trauma specifically. Neurofeedback is a way to quiet that alarm system and help people calm their nervous system down. We use a lot of mindfulness, a lot of yoga, meditation, tons of grounding, lots of gratitude. And then somebody had brought up EMDR, which is the eye movement desensitization treatments, which essentially mimics how the brain works in sleep when you're in REM sleep. So the idea is that both hemispheres of the brain are trying to communicate with each other to try to resolve the daily traumas that we go through to help calm the nervous system in our sleep. EMDR just helps you process a trauma, moving your eyes or tapping or using both sides of the body to help both sides of the brain communicate to reduce trauma symptoms. I am an ITR therapist, which is the instinctual trauma response method, and it kind of pulls from all these modalities to access creativity in the brain, to help the brain put the whole narrative together. I use art. We use drawings to teach the hippocampus that the events are over and in the past. It reduces symptomatic responses, and it kind of draws on all of the science that we know today. I'm sure there's much, much, much more to come. Narrative therapy is really important. So all of this can be used in combination to help reduce the trauma responses that you guys may be experiencing or that your clients may be experiencing. And it helps us get a whole picture of what we have survived, how we became who we are today, learning how to reconnect with our whole body, with our whole mind, with our whole spirit, and trying to be free of the burdens that the trauma comes with and be as present as possible. So it's okay to ask for help. If you guys are county employees, you can always look at your insurance card and ask member services for a local therapist. You can, interview therapists, make sure that they are trained in trauma. You can always call the Suicide and Crisis Lifeline, and that number is 988. Baltimore County has mobile crisis, and the phone number is up on the screen if you ever need it. You can always talk to your supervisors. You can always talk to your coworkers. And I think we should be having really open and robust conversations about mental health care to reduce the stigma and allow everybody to access mental health treatment as you need it. Okay. So the end, that is the end of my presentation. I'm happy to take questions. I know I gave you guys a ton of information. But yeah.
Awesome information. Awesome. So somebody asked, have you used cranial electrotherapy stimulation therapy with any successful relief in symptoms?
I have not. I have had 4 clients in tandem with the trauma art and narrative therapy that I do. I have had them do TMS therapy. And there's a podcast out, the Huberman Lab has a really good podcast on it. And Stanford kind of is like the leading people who are starting, to really see really positive, impactful effects of TMS therapy, which is transcranial. Sorry, my brain just went offline. What does TMS stand for? So it's using magnets and some tapping on the skull, and they map your brain, and it kind of wakes up parts of the brain that go dormant with depression. And I've had 4 clients go through it. All 4 clients, except for one, had migraines, so she had to stop. But my 3 other people had really positive effects and a significant decrease in depression symptoms. I personally am not trained in that. Yep. I hope that answered your question.
Great. Somebody else asked for the name of the book again that you were advocating for.
It's called The Body Keeps the Score.
Great.
What exactly is narrative therapy and journaling? Oh, and then I'm going to answer this question, and then Terry, I'll get to you. Okay. So narrative therapy and journaling. Well, journaling is a really broad tool that we love to use in therapy. And it can be whatever is useful for you. I like to be very specific in journaling, making sure that we are checking in with our true grounded selves and paying attention to all of the emotions and journaling about all the emotions that come up during the day and all of our kind of negative thinking and really acknowledging it. And so there's like a whole process around that specific kind of journaling. I'm not sure if Dean is on here to help explain narrative therapy. But the way I see narrative therapy is just a way to really honor your story and to really honor your whole story and to help you really see like the narrative of your life and how you have successfully survived and come out on the other end. There are lots of narrative therapists that are out there. ITR uses the narrative of your trauma experiences to kind of honor how your brain and your body work together to protect you. So it's just a really broad, based kind of therapy that just really just honors who you are as a whole person.
Great. Somebody points out Baltimore County also offers EAP, or Employee Assistance Program, for the volunteers. So thanks, Phil, for that. And then, as we know, Dr. Dean Krishner is on the call too. He's very involved with the CISM group, which is also a resource available to our career and volunteer first responders. Dr. Krishner, you're welcome to chime in as well. And Terry, do you want to get Terry to chair too?
I'll just say hello.
Hey, Dr. Dean.
Is that Dean or Karen?
Hello. Yes, it is.
How you doing?
Hello. Wonderful presentation. I've enjoyed listening to you.
Oh, thank you very much.
Hey, do you wanna
Dr.
check-
Yeah, sorry. Dr. Dean, did you have anything that you wanted to say about the CISM team or services that you offer?
Well, there's actually two different parts to this now. There's the critical incident stress team, and there's also the peer support team. It's actually the same team, but it serves different purposes. When there is a significant trauma call or a significant call that affects EMS fire personnel, the request can be made to have a CISM team or a CISM team member come out and visit. The peer support team is quite similar. And there's also Wednesday night drop-ins for peer support as well. So those are two different things that are available for fire and EMS personnel in the event that you're having a difficult time with a call or some issue that you just want to reach out and not be alone and have some support.
Awesome, thank you.
Terry?
Yeah, first, Sarah, thank you for the presentation, and Sean, thank you for putting up with my persistent nagging to get Sarah to present. I just want to kind of share two things really quickly. One is that, I was diagnosed with CPTSD among a number of other things, and I've lived with it for most of my life. I had tried everything. I tried cognitive behavioral therapy. I tried tapping. I tried EMDR. I tried hypnosis. I did group therapy. I did private therapy. I went through 6 different therapists. And I was finally told by so-called experts in trauma that I was just going to have to learn to live with it. That it was just, this is as good as it gets. And that I will never be able to, I'll never be cured, but I'll just have to learn how to manage the triggers. And I thought that that was what I was going to have to live with. During the course of COVID, many other factors came up, and it culminated with one trigger being hit. It was just me walking across a crosswalk. Somebody went by me on a bicycle. I had a startle response, and my response was I wanted to pull him off the bike and just beat him to death, which is obviously not a normal response. And that was kind of the final straw for me of that I had to try something else. So I did go to ITR therapy. I was a complete skeptic. I thought it was a lot of feely, touchy crap, and I did not think it was going to work at all. And I figured this is going to be the end of everything. So I'll just tell you all. It's been a year, a little over a year now. I've been working with Sara, and not only have I not had any triggering episodes in several months, it has completely changed my life, and I'm starting to completely rebuild to where I really never thought I was going to live again. And I've been a provider now for 27 years, 25 of those in Baltimore County, and this, living with PTSD is really what kind of put my career to an end. And now I can kind of see it starting to come back again. So, for those of you who are out there, we always pay it lip service. How many presentations has Sean brought us where we have said, oh, get help, or get your friends help, or check on your buddies. And we talk about it, but we don't actually do it. We still have tremendous stigma in our fire service about getting help. And I would just tell you, no one's going to walk into the station and say to you, your partner, and go, hey, I think I have PTSD. But instead, we all know that one guy in the station that flies off the handle because you didn't put the medic back the way they think it should be put back, or the one firefighter that everybody just thinks is an asshole. Excuse my French, because they have such a temper. I would just tell you that is how the trauma presents. And until we either see it in ourselves and go, you know, I don't live like this, or we pull our peers aside and say, hey, bud, that was a totally disproportionate response to that. What's going on? Hey, let's get you some help. Let's get you in some programs. We are going to continue as a organization to kill ourselves and eat our own. So I'm just going to put the plug in there for anybody who is dealing with this, who's suffering from it, or sees these symptoms in their peers. It is never going to present like a textbook, and that there is hope. That's all I can say, because I was told by the so-called experts that there was no hope, there was no cure. This is as good as it gets. And since I've been really digging deep and working on a lot of the trauma, it's given me my life back and given me a completely different life. So for that, I'm just very grateful.
Terry, hi, it's Dr. Dean. I want to compliment you on your courage to stick with it. Not every treatment intervention is for every person. And the fact that you didn't give up and that you continued to search for what would work for you is a tremendous testament to your courage and your strength. All these different programs that you mentioned, some work for some work for others. And everybody needs to realize there is a program for you. Not everyone fits for every person. So keep going until you find the one that works for you, and one will work for you.
Absolutely, Dr. Dean. Thank you.
Terry, and I'll just add my thanks for sharing so vulnerably and being such a voice for treatment for our and self-care for our members. It's totally, your story is inspiring. Thank you.
Thanks for sharing, Terry. Oh, I
Sarah,
see.
you couldn't be smiling more.
I'm fighting back.
Watching your face as Terry told that story was something.
It's just been an amazing journey, truly. So Russ Z says, I'd suggest that we need to look out for each other and point people to help or help to people. So I love that. I agree. I could not agree more.
Great. So any other comments or questions? We Ashley put in the chat a link for your CEUs. If you click the link, I just reposted that into the chat as well.
Thank you.
Sara, thank you. Thanks for the work that you're doing. Thanks for being here tonight. We could hear your bulldogs a little bit snoring in the background.
It's a part of therapy.
Total part.
That rhythmic, hypnotic noise.